Hi, everybody. This is Erica Mello, and welcome to episode number 158 of Tough to Treat. And in this week's shorter episode, I am talking about how to assess the knee differently. Susan and I have done some episodes in the past on the knee. I think one of our first episodes, or one of our, I think earlier in the first 10, was on a patient of mine who had chronic, persistent knee pain. He was a junior golfer and is now, probably going to turn pro. And his driver was his pelvis, ironically, and that's a great episode. I think it's the episode title is, golfer with knee pain. It's early on, like our first 10. I think it's probably number 10, 8 or 9 or 10. And we've taken other episodes steps further with the knee, but we haven't talked about the knee in a while. So I wanted just to do a brief sort of shortie, quote unquote, on assessing the knee differently. And when I say the knee, I'm looking at the tib-fem joint, the PFJ, patellofemoral joint, and the superior tib-fib. So that's the knee in my world, okay? In the episode, I talk about using a body twist as a really great way to screen out issues with the feet and the hips if they're related to the knee. A lot of patients who have knee pain really can't squat. So, for long periods, and you really don't want to flare your patient up the first visit. So I ask my patients, I'm going to have you squat for a bit. Is it okay? So I just had a patient recently who had significant knee issues, and he felt that his hip was the driver. He had the knee treated. It wasn't getting better. But it was very specific. It was his right knee. It was when his right leg was back with running. So it wasn't when his right leg was forward. It was when his right leg was actually behind. And that is a whole different clinical reasoning process for when your patient tells you, okay, when I'm running and it's when my right side, when it's my leading leg. That's a very different movement pattern on your hip and your foot, your whole body, than when that leg is behind. So I also want you to think about that, because when that knee is behind, when that leg is behind, it requires a lot of foot control. That is very, very hard for a controlled foot to do. Okay? And even harder if your anterior thigh, your hip flexors or quads are very tight. Doesn't necessarily mean that the hip is the driver. Many times it is not. It is often some issues with the foot. But I wanted to look at talk about the knee assessment, because what I do is I put my hands on those 3 joints. So we'll just talk about a squat. It'll be easier. I wrap my hand around the front of the tib-fem joint and the back. I'll sort of do a cup, hand around the back, thumb, index finger, depending on how wide the person's knee is, anterior, posterior, and I'll close my eyes and I'll have them squat. Okay, I'm feeling for any kind of abnormal rotation, because ultimately when you squat, you should have some tibial internal rotation, right? I'm feeling for joint line compression is really what I'm feeling for. Both my thumb and index finger or middle finger are on the medial and lateral joint lines respectively. And I'm feeling for any kind of compression. And you'll feel that. I feel it on both sides, both legs, to see sort of what the person's baseline is. And I'll have them squat and I'll assess that joint line compression. Then what I'll do is in standing, I'll see if I can move the patellofemoral joint. Some people are such quad grippers, you literally they can't move their PFJ. So I will look at that. The patella doesn't move a ton when you squat, but I will look at the ability to wiggle, a clinical term there, quote unquote. And then I will go on the superior tib-fib joint, and once again, when you squat, your superior tib-fib, as you go down, should do a little bit of internal rotation, right? But I actually put my hands on the tibial tuberosity, my thumb and my index finger on the fibular head, and I actually do it on both sides, and I close my eyes again and I have them squat, and I'm looking for differences side to side. Okay, so this is a very brief introduction on how I assess those 3 all three parts of what we call the knee joint. In the episode, I talk a little bit more about the body twist. But I wanted this introduction to be a little bit longer because I've had a bunch of knee patients recently, and they're all very different. And it's very important that you really hone in on the movement and the position of the leg that really flares it up. When someone's knee is flared up, going downstairs will bother it. But this patient I was talking about earlier, down the stairs never brought it on. It was long strides of running. That should tell you something. Okay, that should really tell you something. So, hope you enjoy the episode. And once again, if you're new to the podcast, thank you for joining our world. Our website is toughtotreat.com. And if you're looking for another episode, for example, on the knee, just type in knee in our search bar, and it'll come up with all the episodes that have that in as its keyword. And also, we've done a ton. And we were at 158, I think I said at the beginning. So there's a lot of episodes. So if there's any other questions you have or regions of the body that you want to listen to, just type it in their search bar, and then you could listen to it on the website or listen to it wherever you listen to your podcast. Enjoy the episode. Hey everybody, I just wanted to give you just a quick sort of clinical pearl with regards to knees, knee pain. So we've done, I think we've done several podcasts on knee pain over the years. One really early on, a junior golfer I treated, actually, I think that was podcast number 10 maybe. He's actually in my book as well. So, as well as in my course that's coming out soon. And it's important to assess the knee in different ways, because a lot of patients who have knee pain, they can't really squat well. They can't go up and down stairs. And if you start assessing the knee, having them squat multiple times, you're just going to flare them up, right? So, I mean, you can certainly do, I'm talking off the table, like you can do all your tests for their knees on the table. But when I see patients who have knee pain, I know the knee can be a primary driver for certain problems, but I often don't find that to be the case unless it's an acute issue. The knee could definitely be in play, but it may not be the primary issue. So I look at the knee a little bit differently. I will watch the person squat, but if it's very provocative, I will not do that. So I actually I have them stand and do a body twist and just take a look at the knee in rotation, like when your feet are sort of in parallel, and I'll just have them go turn right and turn left. And we all know the motions that should happen in the feet and the knees when they are doing a body twist. And if you're not comfortable assessing the knee in that way, just at least look at it and see if it's provocative, right? So, I usually get my hand on the tibia, on the femur and the tibia, and I kind of assess rotation and, as well as, median lateral joint line. That's a whole nother video, but I do that. I also look at the feet in a body twist. But there are many, many times when you have patients who have knee pain and you cannot get them to squat or get them to squat consistently. Because when I assess patients, I ask them, I say, I'm going to have you squat. I'm going to have you do a movement that you're going to need to repeat consistently. Are you okay with that? If they're not, then you need to find something else, right? So a body twist is a generally sort of low load, a way to sort of look at the knee in the back door if that's the only other option available to you. And you know that the foot is supposed to sort of, quote, pronate, supinate, when they're turning, right? So if you have somebody who has right knee pain, right, and you have them do a body twist to the right, that right foot should get rigid, right? It should supinate a little bit, for simplistic purposes here, right? If they cannot develop a rigid lever when they're turning to the right, if they can't sort of, I want to say supinate. If they can't do that and they're complaining of knee pain, well, maybe you can assess the foot as well. That could be in play. It's another way. It's very hard to check thoracic rotation in that position because they're rotating at their hips. I also get behind them and I can put my hands on their PSI, on their ASISs, and I'll take a look at hip rotation. So what's going back to the example of rotation right, When you are rotating to the right, obviously the pelvis is going to go into a transverse plane rotation, right? And if you feel that femoral head, becoming more quote unquote non-optimal going anterior, you feel some medial compression in the hip when they're doing a body twist and they're complaining of knee pain, well, then maybe the hip could be in place. So there's many ways that you can assess the knee if you can't have them do their provocative movement, like a squat, for example. The body twist is a good way to do that. And you could also rule in and rule out other areas. For example, going back to the foot, if the foot is not developing a rigid lever when they're going to the right or supinating, quote unquote, you can facilitate that movement and see if it makes their knee feel better. And if it does, well, then maybe the foot's definitely part of your driver, profile. So I hope that helps, and enjoy.